respected chairpersons, senior anesthesiologists, and my dear friends. At the outset, I must thank the Aster Ramesh group of hospitals for inviting me to this academic feast of heart in the OR. And it's such a privilege to stand in front of so many illuminaries from whom we have been learning over decades on so many things. You know, we can fondly recollect that we were students and the teachers were teaching us, and it's really an honor to speak in front of our teachers. We all err, we all make mistakes, and unless we make mistakes and we learn from them and we get better at what we are, science wouldn't progress. We would routinely, mundanely keep doing the same things over and over repetitively in the OT. Only when we do something new, when we think something new, and when we discover that there is a better way of doing, that's when we see a progress in the field of science. So what's the first error that could happen when we have taken up a cardiac patient for a non-cardiac surgery and we are thinking of the errors with respect to fluid management, electrolyte management, and the acid-base management? The choice of fluid. Just because he is a cardiac patient, is there a particular fluid which is better for the heart as compared to a non-cardiac patient, or it wouldn't matter? Now, commonly, the perioperative fluid that we all choose is lactated ringer. So, is lactated ringer good enough for a patient with heart disease undergoing non-cardiac surgery, or should we choose some other fluid? The answer is lactated ringer, just like for any other patient, would be fine. The resuscitative guidelines speak of normal saline or 0.9% sodium chloride as one of the choice of fluids for resuscitation as well. Would that be okay for a cardiac patient? Well, it is still okay, just like Ringer's lactate, but we know that when the volumes exceed beyond, say, 4 liters or 3 liters, when we infuse the normal saline in higher volumes, the problem of hyperchloremic metabolic acidosis creeps in, and that could be detrimental to the cardiac patient. So that's what we are concerned about. Now, a lot of medical representatives come and meet us and then tell us, try to explain to us that the balanced buffered salt solutions, the plasma, the light, cabilite, other names are the better ones. They have the acetate, they don't have the lactate, they don't interfere with your measurements of the lactate, and they say they also have some other elements, some other electrolytes in them like the magnesium, and if you keep listening, they'll say there's also gold and silver in that. But then yes, are they better for the cardiac patients? Should we think that they are the choice of the fluid for our cardiac patients undergoing non-cardiac surgery? Well, not really. The main objection that we have with these fluids is that they are still expensive relatively compared to Ringer's lactate. So just because it's a cardiac patient undergoing a non-cardiac surgery, there is no indication to choose any of these fluids for routine fluid management. But if the non-cardiac surgery is of such a type where there is an indication to use such type of fluids, suppose you speak of, say, liver transplant where you're using large amounts of fluids and you have concerns with using Ringer's lactate, then that would be an indication rather than just a cardiac patient or a non-cardiac patient. Now, I don't know how many of you are still fancied with the Isolite P and Isolite EM. Just because it's a pediatric case and there's a label of Isolite P, many were thinking that it's a pediatric fluid customized for the pediatric patients. That should be the choice for the pediatric patients. Absolutely no. The pediatricians may use Isolite P, Isolite EM, yes, because they see a lot of the kids with dehydration, diarrhea, vomiting, all those things, in the ward setting it is okay. But in the perioperative setting, these fluids are hypotonic solutions and they have no place anywhere in the perioperative locations, preoperative, intraoperative or postoperative period, because we know that if we use these hypotonic fluids in the perioperative period, there is a risk of severe hyponatremia which can precipitate cerebral edema, seizures and even death in the pediatric cases. And it's not that it's applicable only to the pediatric patients, even in the adults also in the post-operative period. If you notice that there's a patient who is being given just 5% dextrose for no reason, with a normal electrolyte balance, normal osmolality, there is no such indication to give the hypotonic fluids in these patients at all. So be cautious, do not use hypotonic fluids in the perioperative period, be it a cardiac patient or a non-cardiac patient. Should we add dextrose routinely to all the patients? This question we encounter especially when we come across the neonatal age group. And I think for quite a number of years, it was quite fashionable to drop dextrose, add it to the burette set and make it into 1% dextrose ringer lactate or 2% dextrose ringer lactate and then administer it as the maintenance fluid to the neonates. It's not a wrong practice, but when we look into the evidence and the guidelines, the suggestion is that unless it is a preterm neonate who have a relatively low glycogen storage, unless you are not planning to monitor the glucose levels often like every hourly or every 2 hourly, unless it is a neonate who is on hyperalimentation therapy like already coming from ICU, there is no role of adding or supplementing dextrose in these patients. Now the colloids seem to be totally out of picture, as much so that an obituary has been written on them, whereas if we just moved back by a decade or 2 decades, the textbooks, the journals, the articles, there was so much research on them, one proving to be better than the other and all those things. So is there any role of using these colloids in the cardiac patients coming for non-cardiac surgeries? Well, it's not that they are totally villains, they should be totally banned. Now if you ask anybody about colloids, first thing that they would say is renal failure, coagulation dysfunction. But they have been used over the decades. If you pay attention to the volume that is being used, the indication for which you are using, and you are cautious that you are not overusing that, it is still okay. Why I am saying it is okay is, instead of giving 3 volumes of crystalloids and ending up in hypervolemia in a cardiac patient, it would make sense to give a 1 volume of colloid if there is an indication. If there is an indication, when I say suppose there is a delay in the blood product arriving to the OT, that's something what I call as an indication. It's not that just infusing 500 ml of a synthetic colloid would result in any of these say renal failure or coagulation dysfunction. Now the cardiac patients, when they come for non-cardiac surgery, also may require blood or blood products at some point of time. So in that event, is there a different transfusion trigger? Now for the non-cardiac patients, there are several guidelines which say that the transfusion trigger could come down to as low as even 7 grams per deciliter. Historically, traditionally, for the cardiac patients, the 10 number was very much obsessed with all of us, because we thought that at 10 there is a perfect balance between the oxygen that is contained by the hemoglobin delivered at the tissue levels, the rheologic properties of the blood and the viscosity of the blood. All these match up to such an extent that the delivery at the level of the tissues would be best, But then this has been questioned again, 10 has become 9, 9 has become 8. But we have realized from the concept of patient blood management that it's not single numbers as transfusion trigger that is important, but it's always the oxygen delivery, oxygen consumption at the tissue level which has to be seen and which is of importance. Is there a timer? Okay. Now, we saw that choice of fluid could be Ringer's lactate. There's no specific just because it's a cardiac patient. Now, we can make an error in volume administration. We could be giving more, we could be giving less, and that could really be detrimental to a cardiac patient. Now, to me, to a non-cardiac patient, you give a little more, give 500 ml more, 1 liter more, the vasculature is able to take it without having any problem. But in a cardiac patient, it might not be so. The margin of error would be much lower. Even 100 ml more, 200 ml more could result in pulmonary edema. So, overfilling could result in pulmonary edema and RV strain like in pulmonary artery hypertension. At the same time, hypovolemia, underfilling is also bad because that could result in hypotension, myocardial ischemia. So, we very nicely in our classroom say maintain normovolemia. But the whole art of anesthesia is how to maintain normovolemia, and that's what we keep learning, refining, practicing, relearning throughout our lifespan. So, the common error that we do is when we are doing a non-cardiac surgery is not to use the dynamic hemodynamic indicators. So, they are available in the non-invasive form to such an extent that you could get the measurements through even your pulse oximeter probe. So, why not make use of that to guide the fluid administration so that you don't administer excess fluid or you don't administer lesser fluid. Now, one of the mistakes that we make is not understanding the cardiac pathology in a robust way. When we ignore the cardiac pathology while making the volume decisions, we are likely to land up in trouble. We keep hammering our students that know your hemodynamic goals very well for all the cardiac lesions. That's what we say parkour. What should be the preload, what should be the afterload, what should be the rate, what should be the contractility of the heart, what should be the rhythm of the heart. If you know these goals, at least you are not moving blindly in an unterrained, unmonitored area. You know what are your goals at least, and you can tailor your anesthesia, you can tailor your fluid management accordingly. So, there has to be clarity in the hemodynamic goals. Make sure that the mean arterial pressure is adequate for coronary perfusion. Ensure that the preload is optimized using stroke volume variation or pulse pressure variation. Once again, don't be too obsessed with the numbers. The problem is when we start monitoring with these, okay, it has to be 14 to 16%. So, we keep chasing this 14 to 16% and we tend to lose the whole picture and then mismanage the patients. Avoid tachycardia and hypotension in ischemic patients and adopt the right ventricular protective strategies in pulmonary artery hypertensions with patients, which was actually discussed in quite detail in the case discussions that we had. So, do not rely on any single parameter. If it's the CVP, don't just blindly follow the CVP. Look at the urine output also, look at the blood pressure also, look at the capillary refill time also. We so underutilize the capillary refill time. Make use of all these parameters which are readily available. When it is single parameter, they tend to be unreliable, but in a combination, they give a better picture and the bigger picture, which is likely to be more realistic. So, we all know about the hemodynamic goals. If it is an aortic stenosis, avoid hypotension and tachycardia. So, usually in the stenotic lesions, we tend to maintain normovolemia and the lower side of the normovolemia. In the regurgitant lesions, we again maintain the preload in the normal regions only, but on the higher side of the normal. So, that's the general dictum that we follow for the valvular heart disease. Aortic regurgitation, avoid bradycardia, maintain forward flow. The impact of fluid errors on valve gradient and regurgitation should be known. You give too much, it could precipitate pulmonary artery hypertension, the pulmonary edema, and stenotic lesions. Once again, if you give more, it's a fixed cardiac output state, it's not going to benefit in any way. Dr. Mahesh sir has already enumerated that the basic fundamentals are very important. We might be speaking of very hi-fi things, but then if our basic understanding is clear, things become much clear. So if it's an ischemic heart disease patient, our understanding of supply-demand mismatch has to be very robust. Fluid overload may impair diastolic function. Avoid low hematocrit causing reduced oxygen delivery. We all tend to be very conservative with respect to transfusion, but in patients who are dependent on the hemoglobin levels, they might not have the compensatory mechanisms to compensate for the lower hemoglobin values. We should be tending to transfuse much earlier. So the importance of stable hemodynamics cannot be overemphasized. Now, most of these congenital heart disease, the balance between the systemic vascular resistance and the pulmonary vascular resistance is what plays the most important role. So avoiding the sudden changes in the systemic and the pulmonary pressures is important, and the errors in fluid administration could result in alteration of the shunt flow. So what's important in these is maintenance of the normal baseline physiology. So a detailed history, detailed clinical examination helps us to try understand what is the normal physiology of the patient, and then we must try to keep the patient, keep the child in the range of the normal physiology as much as possible. When it comes to the errors in the electrolyte management, sodium is one of the electrolyte. Many of these patients tend to have the chronic hyponatremia. We should not be in a hurry just because the surgery is scheduled to correct this chronic hyponatremia in a very rapid way, because we know that we could have central pontine demyelinalysis setting in, which could be far more dangerous and life-threatening. And always the sodium level must be seen in conjunction with the serum osmolality. Hypernatremia could result from inadequate free water replacement, and use of hypotonic fluids in the intraoperative period should not be done. Now, hypo or hyperkalemia is another common electrolyte imbalance that we come across. Now, overcorrection leading to hyperkalemia could lead to arrhythmias, and just like how I said that sodium must be seen in conjunction with the serum osmolality, similarly the potassium levels must be seen in conjunction with the acid-base disturbances. If there is an acidosis, you need to address that as well. So one of the common errors that is done is to failure to replace potassium in chronic diuretic users. Always keep a watch on the ECG also when there are potassium abnormalities. Now, calcium becomes a much more important electrolyte in cardiac disease patient because hypocalcemia can worsen the myocardial contractility. So the emphasis should be on correcting the ionized calcium rather than the total calcium. Magnesium deficiency, we don't often measure the serum magnesium, that could also result in the arrhythmias, and hence we'll have to be cautious about both the calcium and the magnesium levels in cardiac patients coming for non-cardiac surgeries. Especially in patients with pulmonary artery hypertension, we need to be very cautious about the arterial blood gas management in the perioperative period. So failure to detect metabolic acidosis just by giving excessive of the normal saline, what I told in the beginning. Sometimes we make incorrect ventilatory adjustments just to keep the target numbers. See, the target numbers would vary from one patient to another patient. In one patient, maintaining the CO2 level at a higher normal level would be best for him, whereas in another patient, maintaining it at a lower normal level would be best. So it's not that there is a fixed values of ABG and then you adjust your ventilator accordingly to get those, because these patients could be having the chronic disorders of the blood gas, and as a result of that they could be having chronic compensation. Now with your over enthusiastic ventilatory adjustments, you could actually abolish these compensations that the patient has been having. So keep a watch on the lactate trend, that's also important. So in pulmonary artery hypertension, maintain the PaCO to avoid hypercapnia. Even mild respiratory alkalosis may be good. Avoid hypoxia. In one of the discussions it was said that even 100% oxygen would be used along with the pulmonary vasodilators. Avoid acidosis at any cost and prevent hypercarbia, as we know that it increases the pulmonary vascular resistance. Now the cardiac patients are highly sensitive to fluid and electrolyte errors. So the margin of error that we have in these patients would be less as compared to non-cardiac patient, and hence we have to be careful. Hence we have to have a goal-directed therapy. We should have an individualized therapy as what is required for this particular patient. For that we need to have a robust understanding of the cardiac pathology that the patient is having. Only then we can tailor manage the anesthesia for the specific cardiac pathology that the patient has. Thank you.
Thank you, sir. And the session is open for